Good morning, dear students. Today we learn regarding the ascending tract the important topic. This topic is for a 10-mark question. It usually has been asked in each and every paper, which is very important. The pain pathway. Okay, in this each and everything, referred pain, visceral pain, and abnormalities, everything is been asked for a 5 marks, 3-mark question. So it's a very important topic. So we'll read under this heading the definition of the pain, pathways of pain, pain types, visceral pain, referred pain, pain inhibition and modulation, and abnormalities of the pain. We'll see the first the definition. How you define a pain? An unpleasant sensory and emotional experience associated with actual or potential tissue damage. Underlying tissue damage which will lead to a pain. It is an unpleasant sensory and emotional experience associated with actual or a potential tissue damage. Next, pain and its pathway. The pain is carried by a which pathway? We'll see. The receptors. Which are the receptors for a pain? It's a naked nerve endings are the receptors for the pain. The nerve fibers which carries a pain are A delta and C type of a dorsal root ganglion, which is a first order neuron. As I told in the previous class, each and every tract which has a first order neuron, second order neuron and third order neuron, which will help in a transmission of the sensation which is being felt. Okay. So, end of the dorsal horn, it is a delta in the they end up in the lemniscus 1 and 5. C fibers end in the 1 and 2. As you know, the lemniscus, they are the group of sensory fibers, it is a part of which the relay of the pathways will go and help to identify the pathway. So the neurotransmitter for this pain is glutamate and substance P. So dorsal root ganglion, that is A delta and C fibers are the first order neurons at the end of the dorsal horn. Axons of the dorsal horn are second order neurons which cross and enter the anterolateral system, that is a lateral spinothalamic tract. Then this tract will project the specific sensory relay nuclei in the thalamus, that is ventro-posterior nucleus in the thalamus being projected by the pain pathway, that is a third order neuron. Then that will project into the sensory area 1 and 2 and along with that cingulate gyrus in the opposite cortex. So which are the first order, second order, third order neuron for the pain pathway? The first order neuron is dorsal root ganglion. Second order neuron is axons of the dorsal horn which crosses and enter the anterolateral system and the which forms a lateral spinothalamic tract and projects to the specific sensory relay nuclei of thalamus, that is ventro-posterior nucleus of the third order neurons, and it projects to the sensory area 1 and 2 along with the cingulate gyrus. This is a diagram showing a dorsal horn lemniscus 1 to 6. This is 1, 2, 3, 4, 5. These are the group of sensory fibers where they relay in the respective segments. So, in 1, as I told, it is a 1 to 4, 1 to 6, substantia gelatinosa 2 plus part of 3. So, here A delta and C fibers are the ones which carries a pain pathway, right? So, in A delta, mechanoreceptors, nociceptors and cold receptors, they relay in 1, 2, 3, 4 lemniscus, and C fibers also relay in 1 and 2. So, this is the lemniscus representation of A delta and C fibers relay. Okay, these are the initial first order neuron with the tract, pain and temperature tract, that is anterolateral pathway. It starts in the white matter, and immediately after the origin it crosses to the opposite side and the course will begin to the ascending tract. So these are flowchart form representation of a neurons. The first order neuron is dorsal root ganglion. The second order neuron is dorsal horn, which crosses to form a lateral spinothalamic tract. Then ventro-posterior nucleus of the thalamus, where the third order neuron is there. From there the relay will go to the sensory area 1, 2 and a cingulate gyrus in the opposite cortex. This is a diagram. This is a line diagram. This is a textbook diagram. In exams, you need to write the line diagram is better to write than the textbook diagram. So in this line diagram, what you are seeing is the pain and temperature will be carried by the tract, lateral spinothalamic tract. Immediately after origin is a midline. Whenever you draw any diagram of a tracts, you should first draw the midline. You make sure that the tract will cross or it will move in the same side. This and lateral spinothalamic tract and ventral spinothalamic tract will cross. So in order to show that it has been crossed, you should write first the midline. After writing that, you should start from below. It's a ascending tract, right? So initial stage, the first order neuron you should draw that the sensory nerve, pain and temperature will be carried and it crosses immediately after the origin and it forms a lateral spinothalamic tract which ascends and relay in the thalamus, that is BPN, that is the ventro-posterior nucleus of the thalamus. From there the radiative fibers will enter into the sensory pathways S1 and S2. That is a sensory cortex. Okay, this is how you should draw the lateral and the ventral and the lateral spinothalamic tract. In that the lateral spinothalamic tract is the one which carries the pain and the temperature. Ventral one, in the last class I had told, it carries a touch sensation. Okay. So in these are the both are the same diagram, but this is the line diagram which will be easy to write. Then this is a cut section of the spinal cord, where you can see the sensations which will carry from where. So it's a gracilis fasciculus and punatus fasciculus which will be relayed in this areas will carry the sensation dorsal column tract which carries the sensations like touch, pressure, vibration and joint position. That is a proprioception. Then lateral spinothalamic tract. Now what you saw in the previous one, which will be carried by carries the pain and the temperature. So this is a area where in the cut section of the spinal cord, the representation of the sensation carried by that. Then the ventral spinothalamic tract which carries a touch and the pressure. Okay. If you have a time, first you should draw this for each and every tract, whichever been asked for which sensations, then you can draw the tracts. This is a cross section of the right cerebral hemisphere and the sensory areas of the cerebral cortex, which shows a representation of the sensory representation of the cortex. Okay, here the major sensation which is being shown here is hand and the face. Okay, so these are the sensation which has been felt in the sensory cortex. Coming to the subcortical perception, that is cortex, the discriminative and the exact and the meaningful interpretation of the pain and some parts of its emotional components, but the perception alone does not require any cortex. Okay. Coming to the types of pain. So what are the pain? You know types of pain. It's a fast pain or a first pain. Second is a slow pain or the second pain. The fast pain is a bright, sharp, localized. The fast pain is carried by the A delta fibers. The slow pain or the second pain, it is a dull, intense and it is diffuse and unpleasant, which is carried by the C fibers. So sometime in a question they may be asked, answer is same, you should draw the pain pathway, but in a question they make you confusion by asking the fibers which carry the fast pain, write the tract of a fast pain carrying fiber. So it's the same, the way lateral spinothalamic tract you should draw. Okay, A delta which carries a fast pain, C fibers which carries a slow pain. This is a one type of a division of a types of a pain. Second one is superficial pain and deep pain. In deep pain, it is poorly localized, which causing a nauseating, sweating, and changes in a blood pressure. So these are the types of a pain. Then muscle pain, which depends on a adequate blood supply. The Lewis P factor could be a potassium is the one which will stimulate. Potassium and the Lewis P factor which will be causing a muscle pain. Say example, substernal pain and intermittent claudication is a type of a pain. Next, coming to the visceral pain. The poorly localized and nauseating, sweating and changes in the BP, that is autonomic nervous system symptoms of pain. It often radiates or referred to the other areas. Visceral pain will be referred to the other areas. The underlying pain will be one, but it will be showing the other place as a shooting pain. There is a referred pain. Then classical sign of inflammation in an abdominal viscera may be the sign. The difference between the sign and the symptom you know. The symptom is what the patient says you regarding the pain and the tenderness, but a sign is a one where you are going to elicit when you are going to examine the subject. Okay, that is a sign. Here the classical sign of the inflammation in an abdominal viscera is pain and tenderness. Tenderness is the one when you palpate the pain when the subject says a pain, that time he feels is a tenderness. In this you have a pain, tenderness and a BP will be reduced and there will be a sweating. This is regarding the visceral pain. Then coming to the referred pain. This you have already well known and you might have been seen or heard regarding telling this. Okay. So what is this referred pain? The definition of this, it's the site of a pain is one, but the feeling of a pain is a other side. So the examples for this is cardiac pain. This is a standard example where anyone can give. It's a cardiac pain which will radiate to the left arm. Okay, the cardiac pain which will be referred to the left arm pain. So the initial sign of diagnosing of a cardiac pain is a left arm pain is a one. Okay, next, irritation of a diaphragm which will be felt in the shoulder pain. Then distension of the ureter will lead to the refer to the testicle pain. These are the examples of the referred pain. Next, coming to the pain inhibition and modulation. Say you have some pain, you need to inhibit or you want that not to happen. So what you do? There will be a pathway called pain inhibition or a modulation of a pain. So central inhibition factor are stress analgesics, or you can use counter irritants like superficial rubbing of any counter irritants. Then gating in the dorsal horn is a gate pathway or descending pain pathway, inhibiting pathways, and action of morphine or enkephalins. These are the drugs which is being taken for a pain. Then endogenous opioids. These are the pain modulation or inhibition. Then coming to the opioids, how they reduce the pain. The physiological significance of this morphine are that is substance P. Substance P is the one which is decreased due to the activating descending inhibitory system. Repeated use of developed addiction and tolerance of these opioids. Say example, you have some pain, you are going to take any opioids. The repeated use will take for a addiction and it will become a habituation, or the tolerance will develop, because of which the pain will be inhibited. Then many opioids like endogenous or endorphins or enkephalins and also the cannabinoids. So these are the opioids which can be used to inhibit the pain. Next, abnormal and a prolonged pain. Abnormally which will lead for a long pain is hyperalgesia allodynia, phantom pain, and thalamic syndrome. These are all the upright aspects you learn when and where we'll see a thalamus and other ones. The definition this I'm going to explain. What is hyperalgesia? Its name indicates it's a increased sensitivity or lower threshold is hyperalgesia. Hypoalgesia is decreased sensitivity or raised threshold. Is a hypo or a hyperalgesia. Next, analgesia. It's a complete loss of a pain sensation or no loss of other sensitivity. Only the pain sensation is lost completely, but there is no loss of other any sensations. Then coming to the allodynia, it is an excessive response to even a mild stimuli or even a light touch is a allodynia. Then causalgia, it's a burning pain due to the trauma. Whenever you see any trauma falling down, you will get a small one. It's a burning pain due to the causalgia. This is a abnormal or a prolonged pain sensation. That is hyperalgesia, hypoalgesia, analgesia, allodynia, and causalgia. Next, coming the other which you can be given a referred pain. This referred pain can be asked for a 3-mark question where you need to write a definition and a example for the referred pain. As I told, it's a cardiac pain which will be felt at the inner part of the left arm and the left shoulder. The second one is a pain in the ovary is referred to the umbilicus. The pain in the testes is felt in the abdomen. The pain in the diaphragm is referred to the shoulder. So this referred pain will give a hint. Means it's a guaranteed one. The referred pain. Whenever they say this pain, you should look after that. Make sure that you rule out the referred pain of the underlying organs. Okay. And pain in the gallbladder is referred to the epigastric region. Then renal pain is referred to the loin. So these are the referred pain examples for the referred pain. So what is the mechanism behind the referred pain? This referred pain is due to the dermatomal rule. As you already read in the anatomy, what is dermatomal rule? It is according to this rule, the pain is referred to a structure which is developed from the same dermatome from which the pain producing structure is developed. So it is a pain, the organ and the area where they refer will develop from the same dermatome. That is a dermatomal rule. The dermatome which includes all the structure or parts of the body which are innervated by the afferent nerve fibers of one dorsal root. For example, the heart and the inner aspect of the left arm originates from the same dermatome. So the cardiac pain will be referred to the inner aspect of the left arm, and so the pain is referred to the left arm. So it's as simple as that. The dermatomal rule, the organ and the referred site of a pain will develop from the same dermatome. So it is a dermatomal rule for a referred pain. Now we will see the definition. It is referred pain is the pain that is perceived at a site adjacent to or away from the site of the origin is a referred pain. The deep pain and some visceral pain are referred to other areas, but superficial pain is not referred. Only the deep pains will be referred. Next, the relief for this pain is, as you know, already you have been taking for a few pains, right? Like headache and myalgia and all. You will be taking the analgesics. Which are the analgesics? The steroidal analgesic, non-steroidal anti-inflammatory drugs, that are NSAIDs, then opiates, morphine, pethidine, and codeine. These are the analgesic drugs. Then, if the pain is severe with phantom pain or any pain which is deep, that should be removed by prefrontal lobectomy, where the frontal lobe is recognized for that pain. Then anterolateral choroidotomy, then posterior rhizotomy. These are the surgical part of removal of a pain, but this is the one which is usually being done for a milder ones. Then coming to the analgesic pathway or pain relieving pathway. Analgesic pathway that refers to the pain transmission is often considered as a descending pain pathway. This analgesic pathway is a descending, but a pain pathway is ascending pathway, right? So the ascending pain pathway being afferent fibers that transmit the pain sensation to the brain. The role of this pathway is inhibiting a pain transmission. The fibers of analgesic pathway arise from the frontal lobe of the cerebral cortex and hypothalamus. These fibers will terminate in the grey matter surrounding the third ventricle and aqueduct of Sylvius, that is periaqueductal grey matter. This is how it is done. Next, third, the fibers from here they descend down to the brain stem and terminate the nucleus raphe magnus situated in the RAS, that is reticular formation in the lower pons in the upper medulla. Then nucleus reticularis and paragiganticus cellularis situated in the medulla. The fourth fibers from this RAS descend through a lateral bicolumn of the spinal cord and reach the synapse of the neurons in afferent pain pathway. They are situated in the anterior grey arm of the synapse. From there, the afferent pain pathway are between A delta, which carries the fast fibers, will be a afferent fibers and the neurons of the marginal nucleus. The C type of a fibers which carries a slow pain afferent fibers and the neurons of the substantia gelatinosa of Rolando. At synaptic level, the analgesic fibers release the neurotransmitters and inhibit the pain transmission before being relayed to the brain. So, which are the neurotransmitters for this analgesic pathway? The neurotransmitter released by the fibers of the analgesic pathway are serotonin and opiate receptor substances, namely enkephalin, dynorphin and endorphins. So, serotonin, enkephalin, dynorphin and endorphin are the neurotransmitter for the analgesic pathway. Now, we will see the gate control theory. What is this? This is being given by the psychologists Ronald Melzack and the anatomist Patrick Wall proposed the gate control theory for a pain in 1965 to explain a pain suppression. According to them, the pain stimulus is transmitted by afferent pain fibers are blocked by the gate mechanism. Say example, there is a pain in the upper limb. That pain should be controlled by a gate. Gate is a one which can be opened or closed. If it is open, it will transmit. If it is closed, it won't transmit. Right? Same way, the pain pathway and the analgesic pathway located at the posterior grey horn of the spinal cord. If the gate is open, pain is felt. If a gate is closed, pain is suppressed. So, what is the mechanism of this gate control at the spinal level? At the spinal level. So, this is the gate control at the spinal level. When the pain stimulus is applied on any part of the body, besides the pain receptor, the receptors of the other sensations such as the touch is also stimulated. When all these impulses reach the spinal cord, through a posterior nerve root, the fibers of the touch sensation, that the posterior column fibers are the one which carries the touch, right? So they send the collaterals to the neurons of the pain pathway, that is cells of the marginal nucleus and substantia gelatinosa. The impulses of this touch sensation passing through these collaterals will inhibit the release of glutamate and substance P from the pain fibers, which will cause a closing of a gate. So, pain transmission is blocked. Say, we will give a best example. When you have any headache, when you apply a counter irritant like Zandubam or a Vicks, that gives a touch sensation, right? That touch sensation will inhibit the release of a substance P and a glutamate, which will close the gate. So, pain will be reduced by the gate control pathway. This is the best example you can have. Next, role of brain in the gate control mechanism. According to the Melzack and Wall, brain also plays in some important role in the gate control system of the spinal cord as follows. If the gates in the spinal cord are not closed, pain signals reach the thalamus through a lateral spinothalamic tract. These signals are processed in thalamus and sent to the sensory cortex. From there, the perception of the pain occurs in cortical level in context of the person's emotional status in the previous experiences. The person responds to the pain based on the integration of all this information in the brain. Thus, the brain determines the severity and the extent of the pain. To minimize the severity and the extent of the pain, the brain sends a message back to the spinal cord to close the gate by releasing the pain relievers such as opiate peptides. Now the pain stimulus is blocked and person feels less pain. Okay, this is a one. Next, summary of today's class is, you know the pain pathway, that is anterolateral spinothalamic tract. Types of a pain: fast and a slow pain, A delta and a C fibers, the superficial and a deep pain, the referred pain. The pain is felt at one side, but the origin is at the other side. Then endogenous analgesic system and the abnormalities of it. Okay. So this is regarding the today's class. I'll give a quick revision. So definition is unpleasant sensory and emotional experience associated with actual or potential tissue damage is a pain. The receptors for this pain is whenever you write for a 10-mark question, it's better to write the receptors which is being activated by the sensation and the nerve fibers which carries that, along with that first order neuron, second order neuron and the third order neuron. After writing that, you should write the line diagram. After the line diagram, put a flow chart regarding the line diagram. Then if you have a time, explain little bit. Then you have to write one applied aspect of each one. Okay. So, it's a receptor for the pain is naked nerve endings and nerve fibers are A delta which carries the fast pain, C type which carries a slow pain. Okay. The neurotransmitters for this is glutamate and a substance P. The first order neuron, this is lemniscus where the A delta and a C fibers will respectively relay. Okay. So they relay from 1 to 6. In that the A delta fibers is for, in mechanoreceptors is for 3 and 4, nociceptors for 1 and 5, the nociceptors and cold receptors for 1 and 5, then C fibers, nociceptors for 1 and 2, thermo and mechanoreceptors for also 1 and 2. This is a flowchart format of a first order, second order and a third order neuron. First order is there in the dorsal root ganglion. Second order is there in the dorsal horn. Next, which crosses to the opposite side, lateral spinothalamic tract. Then ventro-posterior nucleus of a thalamus where there will be a third order neuron. From there they relate to the sensory cortex, that is S1, S2 and cingulate gyrus of the opposite cortex. Okay. Because here they are crossed, no, so it is reached the opposite cortex. This is a line diagram for it. It's the origin, pain and temperature which crosses immediately ascends as the lateral spinothalamic tract and they relay in the VPN, that's the ventro-posterior nucleus of the thalamus. From there they radiate to the S1 and S2 area of the sensory cortex. This is again a diagram of a cross section of a spinal cord. Then types of a pain: fast pain and a slow pain. Fast pain which is a bright, sharp and localized, carried by the A delta fibers. The slow pain which will be a dull, intense, diffuse and unpleasant, which will be carried by the C fibers. The other type of classification is a superficial pain and a deep pain. Deep pain is usually poorly localized, which is nauseating, sweating and changes will be there in the blood pressure. Then the muscle pain depends on adequate blood supply. The factors which will be causing a muscle pain is Lewis-P factor and along with the potassium. The example for this is the substernal pain and the intermittent claudication. Then the visceral pain is a poorly localized which causes nausea and sweating and changes in a BP. These are all the autonomic nervous system symptoms. It often radiates or referred to the other areas. The classical sign of the inflammation is the pain, tenderness and a decrease in the blood pressure and sweating. The referred pain, as I told, the underlying cause will be somewhere else and the pain will be referred at somewhere else. So the best example for this is a cardiac pain, which will be referred in the inner aspect of the left arm. This is because of the dermatomal rule. The heart and the inner aspect of the arm will be rise from the same dermatome. There is a dermatomal rule for the referred pain. The other examples are irritation of the diaphragm, which will be referred to the shoulder pain, distension of the ureter, which will be referred to the testicle. Then pain inhibition is usually done by the central inhibition by the stress analgesia, counter irritants, gating in the dorsal horn, descending pain inhibiting pathways, action of the morphine, enkephalins, and the endogenous opioids. Opioids, usually it is endogenous opioids like endorphins, enkephalins, and cannabinoids. Then abnormal pains like hyperalgesia, hypoalgesia, allodynia, phantom pain, and a thalamic syndrome you learn in a thalamus. So what is this hyperalgesia? It's the increased sensitivity or lower threshold. Means the less the stimulus, the pain will be more. Then hypoalgesia, decreased sensitivity or rise threshold. Then analgesia is a complete loss of a pain sensation or no loss of other sensitivity. Allodynia is an excessive response to even a mild stimuli or even a light touch. Causalgia is a burning pain during a trauma. These are all the single line answers. This can be asked for our MCQs or in a Viva. So other examples for the referred pain are a pain in the ovary is referred to the umbilicus, pain in the testes is felt in the abdomen, the pain in the diaphragm is referred to the shoulder, the gallbladder pain will be referred to the epigastric pain, renal pain referred to the loin. Mechanism, as I told, is the dermatomal rule. The definition of this is a pain that is perceived at the site of adjacent to or away from the site of the origin. Usually deep pains are the one which will be referred rather than the superficial pain. Then relief for this is analgesics like steroidal or NSAIDs, non-steroidal anti-inflammatory drugs, opioids, morphine, pethidine or codeine. The severe pain which cannot be controlled by this analgesic can be done by the surgical way like prefrontal lobectomy or anterolateral cordotomy or posterior rhizotomy. These are the rare procedures can be done for the severe pains. Then analgesic pathway. The neurotransmitters which will be there for an analgesic pathway are enkephalins, serotonin, enkephalins, dynorphin and endorphins. Gate control pathway is given by the scientists Ronald Melzack and anatomist Patrick Paul. What they say is whenever a gate is closed, the pain is suppressed. Whenever a gate is open, pain is felt. So for this, the best example is whenever you have a headache, when you rub any counter irritants, the touch will be inhibit touch will cause a close of a gate, which will be pain will be suppressed by that. Okay, so this is regarding the pain at today's class. So for tomorrow, see whatever we do in the CNS, you need to read today and that day only, and you need to practice the diagrams. Here main important is tracts. The tracts which will be asked for a main questions. So you need to practice very well the tracts. If you won't do on the same day 100% sure that you will forget and you won't be giving any importance for writing. You can be thinking that at the end you can practice, but now if you won't practice the line diagram, it will be very difficult to write. Okay, thank you.